In this second module, we will focus on understanding the patient. This is the patient who is living with diabetes and who is also at risk of diabetic retinopathy or already has diabetic retinopathy. In addition, the patient may also have visual impairment from diabetic retinopathy. Where is this patient? What services do they need? What difficulty do they have in accessing the service? And how can we address these difficulties or barriers in our context? We will explore these issues in this module. What does it mean to put the patient at the center of eye care? You may want to pause here and reflect on this question before proceeding. Putting the patient at the center of care services means that we have to find the patient that needs the service, rather than wait for them to find the service. We have to empower the patient to control diabetes and diabetic retinopathy. We also have to identify their needs and connect them to a service that meets these needs. Finally, we have to evaluate whether we have met our needs and aim to continuously improve the service. To begin with, where is a patient with DR? Diabetes eye care services are mostly offered within eye care facilities. However, the majority of the patients who are at risk of DR do not visit the eye care facility. Instead, they can easily be found at the diabetes clinic. They can also be found within diabetes support groups. In addition, they can be found at the work sites, they can be found in schools, they can be found in social places such as religious places. How can we reach them in these places? How can we leverage on these places to strengthen diabetes eye care services? Is it possible to work with the diabetes service to strengthen referral to the eye clinic? Is it possible to place a fundus camera at the diabetes clinic in order to do retinal screening at this clinic? Can we hold outreach meetings and health talks with support groups? Can support groups link the patients to the eye clinic? Can we hold screening services in schools and work sites on a mobile basis? Think about your own setting. Which services can you leverage on to improve the access of these patients to diabetes eye care services? Even when patients are referred to the eye care provider, they often have difficulty navigating the health system. The referral service may be ineffective, and the patient may need to visit on multiple occasions before they get the service. Patients with DR may have visual impairment and mobility problems, and therefore may have difficulty with multiple visits to the eye clinic. They may also not be able to pay for multiple services. How can we address these problems? How can we strengthen the link between the services the patient is already receiving and the eye care services? Both diabetes and diabetic retinopathy have potential to adversely affect the quality of life of the patient. A patient with visual impairment will have difficulty measuring the dose of insulin and administering that dose. A driver who has visual impairment from diabetic retinopathy may lose his job and lose economic independence. A student who has mobility problems because of visual impairment from diabetic retinopathy may drop out of school because of difficulty in accessing educational facilities. Many of these patients may get progressively isolated. Their emotional well-being may also be seriously affected, and they may even get into depression. How can our services maximize the quality of life? How does diabetic retinopathy affect the quality of life in social functioning, in leisure, and other aspects of life? We will explore this in greater detail in the course. Putting the patient at the center of eye care means engaging with the patient. There are various strategies for patient engagement. Self-management education empowers the patient to control diabetes and diabetic retinopathy. Person-centered care improves patient satisfaction and other patient-reported outcomes. Peer support helps the patient to link with the service that they need. In which way can you apply these strategies in your own setting to improve access to diabetes eye care services? Although screening for DR is both effective and cost-effective in the control of DR, there are various barriers to access to the service. Some of the barriers are distance to the health facility, cost, awareness, transport, lack of a companion, fear, and poor understanding of the importance of screening. These barriers are particularly important in low-resource settings. In such settings, the patients may live far from the health facility, and geographical distance may mean that the patient has to take multiple routes or multiple vehicles to reach the health facility. What solutions can be used to address this barrier? Both direct and indirect costs may mean that the patient cannot visit the health facility. Are there solutions to address this? We will explore this in greater detail. By the end of this module, you should be able to explain how DR affects the quality of life. You should be able to engage the patient in care, identify pragmatic opportunities to control DR in the community and in private care, and identify the barriers to DR screening in your setup. The materials that are shared in this course are free to use, reuse, and to share, as long as you attribute, use them non-commercially, and share alike using the same license. We hope you enjoy the course and that you find it useful.